Hello and welcome. In this lecture, we are going to explore a very clinically relevant topic: pharmacologic management of postmenopausal symptoms. Menopause is not merely cessation of menses. It represents a profound endocrine transition that affects multiple organ systems: skeletal, cardiovascular, neuropsychiatric, urogenital, and metabolic. As pharmacologists and clinicians, we must understand the physiology behind symptoms, the molecular targets of drugs, risk-benefit assessment, individualized patient selection. So, let's start. The learning objectives are shown. Please take a look. By the end of this session, students should be able to: first, understand the pharmacological approach, meaning when to use hormones, when not to use hormones, and when to use alternatives. Second, classify drugs used in postmenopausal women and explain their mechanisms and adverse effects. Third, compare closely related drugs, for example, tamoxifen versus raloxifene, estradiol versus ethinyl estradiol, natural progesterone versus synthetic progestins. Notice that this is not memorization-based pharmacology. This is mechanism-driven decision-making. Menopause is defined as 12 consecutive months without menstruation in a previously menstruating woman, typically around 50 years of age. However, the transition is gradual. Perimenopause may last years, during which hormonal fluctuations are erratic. The core physiological event is ovarian follicular depletion, leading to reduced sex hormones and increased gonadotrophins. The endocrine shift affects multiple tissues that express estrogen receptors: bone, brain, vasculature, genital tract, breast. Thus, menopause is systemic, not local. The decline in estrogen explains most symptoms, including vasomotor, genitourinary, neuropsychiatric, cardiovascular, musculoskeletal, etc. Let's talk about them in detail. Vasomotor symptoms. Hot flashes are due to hypothalamic thermoregulatory instability. Estrogen modulates central serotonin and norepinephrine pathways. When estrogen declines, the thermoneutral zone narrows, small temperature changes trigger vasodilation and sweating. Genitourinary symptoms. Estrogen maintains vaginal epithelium thickness, lubrication, and urethral integrity. Decline causes dryness, dyspareunia, recurrent UTIs. Neuropsychiatric symptoms. Estrogen modulates serotonin, dopamine, and acetylcholine, hence mood swings, anxiety, insomnia, brain fog. Long-term risks, such as osteoporosis due to increased osteoclast activity, cardiovascular disease due to lipid changes, endothelial dysfunction, among other factors. Thus, therapy may target symptoms as well as long-term prevention. This slide summarizes treatment by condition. Notice the hierarchy. Lifestyle modification is foundational: exercise, diet, weight control. This slide represents individualized medicine. Take your time to carefully explore it. Estrogens act via nuclear receptors. Estrogen receptors alpha, and estrogen receptors beta. These regulate gene transcription. Membrane receptors are coupled with G proteins and are involved in rapid signaling. They activate MAP kinase or cyclic AMP systems. The genomic effects alter protein synthesis, hence take minutes to hours to act. Non-genomic effects act rapidly. Estrogen receptors alpha is prominent in breast and uterus, while estrogen receptors beta is more involved in bone and cardiovascular system. This receptor distribution explains tissue-selective responses. Estrogens stimulate all types of estrogen receptors, just like endogenous estrogens, for their favorable effects. They help relieve hot flashes, improve lipid profile, and preserve bone mass. Estrogens in females are quite well known to favor bone formation because they primarily increase the osteoblastic activity. However, there are side effects of estrogens as well. For example, an increased venous thromboembolic risk, and increased likelihood of breast and genital tract cancer. So long-term therapy with estrogen has to be taken into consideration, given these potentially life-threatening side effects. An important concept is that the estrogen must be combined with progestin if uterus is intact, to prevent endometrial hyperplasia. Starting HRT early, less than 60 years, may have better cardiovascular profile. This is called timing hypothesis. A chemical classification of estrogens is given. The use in HRT or in contraception considers this aspect. This would be clearer in our next slides. Please note that diethylstilbestrol is now obsolete due to carcinogenicity. Estrogens are used for hypogonadism, postmenopausal HRT, as well as contraception. However, the goal and hence the dose and selection differ. In HRT, replacement with low physiological dose. In contraception, ovulation suppression with higher inhibitory dose. Same receptor, different objective. Common adverse effects of estrogens include nausea, mastalgia, and migraine exacerbation. Serious ones include increased risk of thromboembolism as hepatic clotting factor synthesis is increased, and carcinogenicity of breast and endometrium. The historic DES is a classic example of a drug that is linked with a type D or delayed adverse reaction. Selective estrogen receptor modulators act as agonists in some tissues and as antagonists in others. Thus, these drugs are given to circumvent and avoid the harmful effects of alpha receptor stimulation of estrogens. For bone mineralization, we need the activity of beta receptors. So instead of estrogens, which will stimulate both receptors, it is quite beneficial and desirable that we may use drugs which just stimulate beta receptors. And this is exactly what selective estrogen receptor modulators do. There are different drugs, but we prefer raloxifene as compared to others, because they have minimal effects on uterine endometrium, because if you keep on stimulating uterine endometrium, there will be abnormal uterine bleeding and menstrual problems. So to avoid that, raloxifene is a good choice. Selective estrogen receptor modulators, they act as agonists in some tissues, antagonists in others. Raloxifene, antagonist in breast and uterus, agonist in bone. Tamoxifen, antagonist in breast, partial agonist in uterus. This is receptor coactivator, corepressor biology. This table compares various SERMs. Please take time to dive into it. The key highlights are as follows. Tamoxifen increases endometrial cancer risk. Raloxifene does not, but both increase venous thromboembolic risk. Ospemifene acts on vaginal epithelium. Basedoxifene, combined with estrogen to protect endometrium. Progesterone is the other gonadal hormone in females, which is essential to maintain pregnancy. It is produced by corpus luteum during normal menstrual cycle, while from placenta during pregnancy. There are two types of receptors, PRA and PRB. Like estrogens, these receptors have nuclear and membrane-bound receptors. Thus, both have genomic and non-genomic actions. A chemical classification of progestins is given. The use in HRT or in contraception considers this aspect. This would be clearer in our next slides. Progesterone maintains pregnancy by suppressing GnRH pulses, making cervical mucus more viscous, inhibiting myometrial contractions, inducing a secretory transformation of endometrium to support developing embryo. Progesterone stabilizes endometrium in HRT. Also, promotes mammary acini development. This table compares various hormones acting on breast. Please take time to dive into it. The key highlights are as follows. Estrogen for ductal growth. Progesterone for lobulo-alveolar development. Prolactin for milk synthesis. During pregnancy as well as used as contraceptives, high estrogen and progesterone inhibit lactation. After delivery, there is a drop in estrogen, progesterone that would let prolactin acts. Among postmenopausal women, HRT dosing mimics normal physiological ranges in a non-pregnant woman, not as high as with the case of contraceptives or pregnancy. Progestins are used in HRT to protect endometrium, but in contraception to ovulation suppression due to higher dose or longer action. 19 NOR compounds preferred in contraception. MPA can be both HRT and injectable contraceptive, same hormone, different dose. Recall that the estrogen must be combined with progestin if uterus is intact, to prevent endometrial hyperplasia. This table compares the use of estrogens and progestins. Color coding helps quickly compare a particular use. Please take time to dive into it. The key highlights are as follows. Estradiol in HRT, ethinyl estradiol in contraception, MPA for both, but at a different dose. Here is a summary of hormone use as HRT in postmenopausal women. A comparison with hormone use as contraceptives in reproductive age is also given to clarify the difference. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!